Greetings, I will talk about the Untitled project. Altered left atrial blood flow hemodynamics in atrial fibrillation patients has been implicated in atrial thrombus formation, which is a precursor to embolism and ischemic stroke. Real-time phase contrast may be best to measure this. Our group has been using real-time phase contrast MRI in AF patients by acquiring a 2D oblique plane slice in the LA parallel to the mitral valve as shown here. We do have to segment the left atrium in order to restrict our calculations to it, which for one frame is really easy. However, as we have many hundreds of frames over several heartbeats, segmenting each frame is no longer feasible, especially clinically, which limits the impact of this technique. The purpose of this project was to develop an artificial intelligence or AI deep learning tool to automatically segment the left atrium in 2D real-time phase contrast scans. For this project, we had 34 AF patients yielding 39 total scans, with scan parameters shown below, noting that segmentation would take around 10 to 30 minutes to perform for each patient. The data can be thought as a 2D spatial dimensions of 144 pixels and 1D temporal dimension of 60 to 300 plus timeframes, depending on how many heartbeats were required, creating a 3D data set. From these segmentations, flow quantification such as peak velocity in the LA, the incidence of loss is lower than roughly 7 centimeters per second per pixel through the cardiac cycle, known as low velocity incidence, and mean flow were computed. These, as well as a shape descriptor, the DICE score, will be used to evaluate the AI versus manual performance. Before I talk about the AI methodology, I briefly want to talk about two things that differ from a typical AI segmentation project. First, our ground truth was created by a manually driven process where a user would load the 2D real-time phase contrast data and draw the basic shape of the left atrium on one slice. Then, using a region growing tool in MATLAB, this is grown through 30 iterations on that and subsequent time slices as shown here. You can probably note within that demonstration there were slices that were missing parts of the left atrium are extended beyond it. The bulk of the time segmenting came from manually reviewing and changing these slices. This is important for two reasons, as the majority of the segmentation comes from a region growing algorithm with user input that should be easy to learn, and the rest comes from cleaning it up, which may be harder and require the deep learning complexity. The second component that separates from a standard segmentation project is that the data was split into temporal blocks. It was also cropped spatially. This was done to facilitate hardware requirements for training, but also forces the network to only use local heartbeats, typically 3 to 4 within each block, to inform its segmentation, which may help limit unneeded complexity and overfitting. Each block is then segmented by the network, as shown here, and then will be stitched back together to give one patient's worth of segmentation results. Here is the network architecture used for segmentation. We used a 3D dense unit convolutional neural network with architecture that has been shown to be extremely proficient in 4D flow aortic segmentation and promising in 4D flow left atrial segmentation in atrial fibrillation patients. The data input here is going to be just the magnitude images that are cropped. We use the manual segmentation shown on top of it here as ground truth using logit and DICE score loss functions. The output is an AI mask shown here on the right. We will also be plotting the AI and human mask on top of each other with the AI in white and the manual ground truth in magenta, which we can see through time. Critically, we used 5-fold cross-validation with our hyperparameters from our previous models frozen in order to evaluate our entire data set to interrogate potential overfitting and overall performance of this architecture. If we find performance lacking and need to optimize the model by tuning hyperparameters, we could utilize a nested cross-validation scheme in our future work, or a training validation testing scheme if we have a large enough cohort in the future. Here is the overview of the results based on just 2D segmentation as assessed by the DICE score descriptor, where 0 is the lowest score indicating no agreements between segmentation and 1 is the highest indicating perfect segmentation. Here we can see the best, mean, and worst slices over all 5 testing set folds. Each fold had roughly 9,000 frames of data for training and a little over 2,000 frames for testing. The average DICE score and standard deviation is given for each fold, with the total DICE score for the entire testing sets being 0.91 plus or minus 0.04. Do note that each testing fold had similar performance, underscoring that our model is fairly robust to different training and testing sets and is unlikely overfitting. Further, we did an inter-observer study of 5 patients between 2 humans, which gave an average DICE score of 0.91 plus or minus 0.01 agreements. Thus, our model is fairly comparable when it comes to 2D segmentation as assessed by the DICE score. To get a better understanding of the performance of the model, I am showing the best, median, and worst blocks from testing across all folds. Here we can see the model tends to perform very well in the best and median cases. However, in the worst case, there are many frames of poor performance. This is due to low signals, so model performance being bad isn't too surprising. However, it is disappointing as this also is the case that takes the longest to segment. A future goal of this project is to modify the network architecture to better penalize this and hopefully better segment it. While good agreement between shape of segmentation is great, it is critical that the flow derived from the AI manual pipelines also have good agreements. To assess this, we looked at the correlation and Blend-Altman plots of the peak velocities of each patient and the incidence of low velocities. From these calculations, we saw that the AI and manual derived flow quantifications had great correlation for peak velocity and for low incidence of velocities. Blend-Altmans also showed pretty good agreement with limits of agreement at near less than 10% of the mean. Finally, we also looked at the flow curves, where I am showing the curves for the patients with the best DICE score, the median DICE score, and the worst overall DICE scores. Overall, the shape between the AI and the manual agree excellently for each patient. Even in the worst DICE score patient, poor frames are rare and only impact a few time points, and the flow curve as a whole tends to agree. To conclude, we were able to train an AI to segment the left atrium in 2D real-time phase contrast scans. We used 5-fold cross-validation and demonstrated that the model had good results for 2D left atrial segmentation that performed at human level. This good result was further corroborated by agreement in flow quantification and mean flow. Our goal for this project is to expand the cohort and better penalize low-performing frames with training and testing. I'd like to thank all of my collaborators and colleagues, and you for watching and listening. Thank you.